Everybody, my name is Tom Chandler. I'm Dean of the Arnold School. I want to thank you all for coming out on such a beautiful springtime afternoon to hear a very interesting, exciting lecture by our distinguished visitor, Ken Langa. Thank you for coming, Ken. Before we begin, though, I just want to remind everybody that the reason we're able to come here today and have this kind of an event is really through the generosity and benevolence of the Arnold family. Jerry Sue and Norman J. Arnold gave a gift of about $7 million in January to establish essentially a virtual institute on aging. And part of their wish for the use of that money was to bring distinguished researchers, particularly researchers in dementia, researchers in Alzheimer's, to campus and to share with us their ideas about the disease, research, treatment, advances, and so forth. Jerry Sue is still with us. Norman died a couple of years ago. But Jerry Sue's mother died of Alzheimer's after an extended illness. And I'm sad to report that Jerry Sue is in the early stages of that disease herself, otherwise she'd be here with us today. So it's a very appropriate topic. And again, Ken, thank you for visiting with us. This funding was used to establish the Arnold Institute on Aging, with this lecture series being part of that goal. The Institute also focuses at the other end of the age spectrum, in childhood development, childhood obesity prevention in particular, and we have an annual lecture in that area every year as well, usually in the fall, organized by Michael Beach and others that are working in that area. Now, most of you in the room probably realize this already, but there was a report released last week by the National Alzheimer's Association that showed that our state has the highest mortality rate in the country from Alzheimer's disease. Alzheimer's is the 6th leading cause of death presently in the United States. And in South Carolina, we have an estimated 89,000 citizens suffering from Alzheimer's disease. And that number is just going to continue to grow as my generation, the baby boomers, will continue to age. The other statistic that's often overlooked with that disease is that just in South Carolina, more than 300,000 family members and caregivers are also severely affected by the disease. Now, the Arnold School has a long and proud history of work on this important issue. It dates back several decades. In '88, we established, this even predates me. In '88, the school established a Dementia Study Center to serve as a research hub in support of the nation's first comprehensive statewide registry for dementing illness. That pioneering work led to our school's present Office for the Study of Aging, which serves as the home today for what's now known as the South Carolina Alzheimer's Disease Registry. Most notably, this year marks the 30th anniversary of the Alzheimer's Disease Registry, and I think it's the oldest registry in the country for any state. And each of you should have just received the 30th anniversary report on your chair, which you can read at your leisure, but not during Dr. Langa's lecture. That's fresh off the press. That report will provide you with a lot of interesting information about Alzheimer's statistics for South Carolina, but it also reflects on the many partnerships that are needed to conduct this kind of important work. And it really is a collaborative effort. Again, I'm sure as Ken will stress, to do research and outreach in Alzheimer's. Now, to that end, the Office for the Study of Aging has been absolutely instrumental in bringing this lecture together. And I'd just like to take a moment to recognize Daniela Friedman and Lee Pearson, who co-direct the office, for their efforts in this lecture today. So thank you both. So you've heard enough from me. Daniela, if you'd come up and introduce our speaker. And again, thank you all for coming out.
Thank you, Dean Chandler. Thank you, everyone, for being here. Before we introduce our guest speaker, The Office for the Study of Aging really benefits from a lot of partnerships and active input from stakeholders from across South Carolina. So I'd like to recognize some of our partners who are here today. We have Dr. Victor Hurth, who I saw right here. He's the Chief of the Division of Geriatrics at Palmetto Health, University of South Carolina Medical Group, and Senior Primary Care Practice. Daryl Broom, who's the Director of the Lieutenant Governor's Office on Aging. He's right here. He is right here. I thought I saw him sneak in. Thank you for being here. Elizabeth Ford, our Alzheimer's Resource Coordination Center Manager for the Lieutenant Governor's Office on Aging. Teresa Arnold may be here, AARP South Carolina State Director. Brenda Heilman, Director of Palmetto Care Managers and a previous Director for the Office for the Study of Aging. Cindy Alumni, President and CEO of Alzheimer's Association South Carolina. Beth Solkowski, Vice President of Communications and Advocacy for the Alzheimer's Association South Carolina. Taylor Wilson, all sitting in a row in purple, Director of Communications and Advocacy for the Alzheimer's Association. Thank you. Marty Colucci and colleagues from Lisa's Care Connection are here, and we appreciate all that you're doing for caregivers in the state. We also have partners and friends who have been longtime coordinators and worked previously at the Office for the Study of Aging. Jan Merling is here, and she started the Dementia Dialogues Education Program that's now trained over 25,000 people and just recently became nationally registered as a nationally registered program. We also are very proud of our collaborations that we have across the campus with faculty in different disciplines, and so we want to thank all of our faculty affiliates who are here today. So it's not just Lee Pearson and myself, it is a lot of collaborators and a lot of partnerships, so we really appreciate everybody who's here. And now to introduce our distinguished speaker, Dr. Kenneth Langa has a wealth of academic and research appointments, and I'll just name a few, and you have the beautiful program in front of you. He's the Cyrus Sturgis Professor in the Department of Internal Medicine and Institute for Social Research, a research scientist in the Veterans Affairs Center for Clinical Management Research, Associate Director of the Institute of Gerontology, all at the University of Michigan. He's also Associate Director of the Health and Retirement Study, which is a National Institute on Aging funded longitudinal study of 20,000 adults in the United States, and many faculty and students in this room have been working with this data, and we've had some nice conversations this morning about data and some research. Dr. Langa received his MD and PhD in public policy at the University of Chicago. He is a general internist with an active clinical practice treating adult patients. His extensive research, which we're going to hear about, focuses on the epidemiology and costs of chronic disease in older adults, with a special focus on Alzheimer's disease and other dementias. He's published more than 200 peer-reviewed articles, and he's currently studying population trends and prevalence around dementia, both here in the U.S. and internationally. It's been a pleasure getting to know Dr. Langa as we prepared for this event, so please join me in giving a warm welcome.
Thank you, Dr. Chandler and Dr. Friedman and Dr. Pearson for inviting me down. It's been wonderful to get to know the work that's going on here. We had some talks with faculty and students this morning about the registry and other things, and it's an honor to be here to talk at the first Arnold Aging Lecture, so I really appreciate it, and looking forward to some questions afterwards. I think, again, the plan for me, oh, by the way, I have no financial conflicts of interest, in case you were worried. Here's the plan I have for the talk today, so about the next 45, 50 minutes or so. And again, I think we have some time for questions afterwards. So I'd like to give you some background on dementia and Alzheimer's disease. Many people in this room obviously know a lot about that, but we'll talk some about what it is and what its huge societal impact is. Then some information on the population trends that we think are important to brain health. and actually some optimistic or positive news among the incredible impact that Alzheimer's disease is having. And then again, I'll tell you a little bit about the health and retirement study, the main study I've been working on with lots of colleagues at the University of Michigan, talking about some trends in dementia prevalence, and then some conclusions and future questions. All right, so to start at the beginning, so we're all on the same page, I like to just go over what exactly is dementia and how do we define it. And these are the diagnostic criteria from the National Institute on Aging and Alzheimer's Association, published in 2011. And so dementia is impairment in two of these cognitive domains, memory being the most common in Alzheimer's disease, but other problems with thinking and reasoning you can see there. And then those impairments are severe enough that they cause or interfere with the ability to function at work or usual activities. So basically, one is no longer able to get through the day on their own, this dementia threshold, so to speak, where people go from being able to function and be safe independently to no longer being able to do that. And as you can imagine, and folks who work in this area, and even people with who have this experience with their families, that line is obviously, that threshold is not a clear line, and that's actually one of the complexities and challenges in studying Alzheimer's disease, both in clinics and in the population, is that that's a bit of a hard line to define, and we'll talk some more about that. As many of you probably know, there's lots of research now trying to identify biomarkers, either in the blood or the spinal fluid or in imaging studies of the brain, to try to get a better sense of who is it that has Alzheimer's disease, what is their prognosis, what's their trajectory. Hopefully we'll be able to have a better sense of telling people you have these biomarkers, and therefore we're able to give you a better sense of what your future will be. So what are the causes of dementia? Again, obviously, Alzheimer's disease, the buildup of abnormal proteins in the brain, amyloid outside the cells, a protein called tau within the cells that builds up for reasons we're still not entirely certain about why that happens. We think that Alzheimer's, or it's thought that Alzheimer's disease causes about 60 to 70% of cases of dementia. Then vascular dementia, obviously related to excuse me, blood flow to the brain, problems with atherosclerosis, TIAs, small strokes, changes in the cells that provide blood flow to the brain, thought to be an important cause. And then you can see some of the other rarer causes of dementia here. But actually, one of the important pieces of evidence or important discoveries over the last 20 years of epidemiology and studies of dementia in populations is that sort of clean list up at the top is actually too simplistic, that in fact most cases of dementia in older people, certainly 80 and older, are related to a couple of different causes, usually the Alzheimer's changes in the brain, Alzheimer's proteins, as well as vascular disease. So it's a little more complicated than we thought. That we think that sort of fixing or preventing one of these pathological pathways may not actually prevent dementia because of the complexity of multiple pathologies causing cognitive decline and dementia. So just to amplify that a little bit, this overlap and interaction between the cardiovascular system, vascular disease, and Alzheimer's disease, evolution has actually given us a good hint that blood flow to the brain is very important. So the brain accounts for about 2% of body mass, but actually gets about 20% of blood flow. So 20% of the blood coming out of your heart is actually directed up to your brain, and it also uses about 20% of the body's oxygen. So there's a hint that getting in the way of blood flow to the brain probably is not a good thing. And then the risk factors, again, developed over the last 20 to 30 years of both epidemiologic and animal research and clinical research. Lots of overlap, as you can see, between risk factors, the sort of classic heart disease risk factors, things like high blood pressure, diabetes, high cholesterol, obesity, physical inactivity, alcohol being thought to be protective in some ways, both moderate alcohol intake for the protective of heart disease as well as cognitive decline and dementia. And then genetics, both the main genetic risk factor for Alzheimer's disease, I should say the sort of late onset Alzheimer's disease, is the ApoE4 genotype, which actually increases cardiovascular risk as well as Alzheimer's risk. A number of really interesting studies over the last few years have shown that having more of these classic vascular risk factors, high blood pressure, high cholesterol, diabetes in midlife, so 40s, 50s, 60s, increases the likelihood that you'll have amyloid in your brain in later life. So again, a hint that in some ways it's almost impossible. I've sort of come to the conclusion that sort of picking apart vascular dementia and Alzheimer's disease almost, to me, doesn't make a lot of sense, or actually might be, we might be missing something if we try to separate those, because these risk factors and the pathological pathways seem so intertwined. All right, so with that as background, turning to some of the social and economic impact of dementia. Again, many in the room are deal with this every day and understand these issues, but I think it's good to remind ourselves, as Dr. Chandler said, of the huge impact on patients, families, public policy of dementia and Alzheimer's disease. So here's sort of the central aging issue that lots of the students in the room, I'm sure, have seen some version of this graph over the last couple of years. This is a graph showing the growth in the worldwide population of older folks, age 65 plus. So the green line here is the number of people 65 and older around the world. You can see right about now we're at about 500 billion people, sort of skyrocketing or shooting upwards over the next 35 years or so to about 1.5 billion people 65 and older around the world. So again, that's sort of the central issue of why dementia and Alzheimer's disease we think is important now and going to be even more important in the years ahead. That growth, as many of you know, sort of people are living longer. The demography of the baby boom and age distributions in countries around the world, that's why the green line is shooting up. The other really important thing to notice here is the blue line is the number of children in the world. So the kids age less than 5. And you can see, obviously, that there's this flat line here. So this growing disparity between number of older people and number of younger people. And in fact, we're at a sort of inflection point or a crossing point for the first time in human history, in fact. There will be more older people than kids less than 5 in the world. So obviously the impact around caregiving, again, as Dr. Chandler mentioned, this has huge implications for the number of people that will be around to take care of older adults in general, older adults with dementia in particular. Here's some more information on caregiving. As we talked about, actually the first work that I did with Health and Retirement Study was to try to understand just very descriptively how much time families spend providing care to people with various chronic diseases. And you can see here that dementia is the largest piece of the pie, almost a third of all caregiving for chronic disease. And one of my early conclusions here from this work, very insightful, is that the brain is a very important organ, that dementia, depression, stroke, all sort of making up the most, leading to the most amount of care that people need. So again, not news to all of you, but thinking about dementia not just as a disease that or condition that affects one person, but it clearly affects multiple generations, families, people across the country who are trying to take care of older people with dementia. Here's a study we did, again, with Health and Retirement Study data that my colleague Michael Hurd led, that was published a few years ago, trying, again, using the Health and Retirement Study, which I'll tell you about in a little bit, to get a better sense of the full economic impact of dementia in the United States. And the punchline there was that we estimated that about, for every case of dementia, cost about $50,000 per year in additional economic cost. So in addition to the other medical problems that people have, if someone has Alzheimer's disease or dementia, the cost is about $50,000, translated to about $200 billion nationwide in 2010. That's obviously probably higher now. And again, just to highlight that, again, the main economic impact or the main economic effect of dementia and Alzheimer's disease is just the informal care costs, the amount of time that families need to spend providing care. Nursing homes, long-term care, the other big piece of the pie. Sort of some of the more acute costs, direct costs of treating someone with Alzheimer's disease are relatively less than these large costs of caregiving, daily care that people need. So putting that all together, this big growth in the older population and the economic impact, come to some general conclusions here that we think that without changes in treatments or ability to prevent the disease, there's going to be a large increase in the number of people with Alzheimer's disease and dementia worldwide, from about 44 million now to about 135 million. Again, mainly driven by that, just the fact that there'll be more older people, and because dementia is so tied to aging, that's where that growth comes from. Huge economic impact, again, getting close to $1 trillion worldwide. So again, I don't think I have to convince this group, but really important condition now, likely to become even more important because of this changes in demography and growth in older people. All right, turn into some trends, recent trends that have happened both medically, epidemiologically, and socially that we think have had an impact on brain health in the United States and other places around the world. As many of you know, there's been a large increase in the prevalence of obesity, and along with that, diabetes and hypertension in the United States and in other countries around the world. I'll show you some numbers in a bit. But actually, at the same time, on the positive side, much more widespread and intensive treatment on these conditions. We've have some good interventions. We know how to treat hypertension well. We know how to treat diabetes and cholesterol, and there's been some improvements in our interventions for those conditions. So more people with it, but maybe we're doing a better job of protecting people from the complications of these diseases with some of our treatments. So again, just to show you a few numbers about that, estimated that worldwide diabetes cases, you can see have skyrocketed, tripled since the 1980 from about 150 million, almost tripled, to 350 million in the U.S. Among older folks, you can see this huge increase, about 10% in 1990, 21% in 2011. Less significant increase, but still an increase in people with hypertension in the United States. But again, here's the evidence or the numbers showing that we're doing a bit better job of treating these conditions. So more people being treated who have hypertension, greater number being controlled. We obviously still have lots of room that we can improve, but the trends have been to better treatment, better control of things like diabetes, hypertension, and cholesterol, sort of all trends in that direction. And here's a graph that from a paper in 2014 showing the main vascular complications of diabetes and trends in those complications in the United States. Again, this is just among people with diabetes. You can see that the main vascular complications, so heart attack, stroke, lower extremity amputations, which are usually due to blood flow problems to the legs, have all just dropped incredibly. The heart attack rates are sort of the most eye-popping in some sense, almost dropping 2/3 from about 150 cases or events per 10,000 down to 50 or so. So this is not just from treatments. There's other things going on here, declines in smoking, other kinds of lifestyle issues, but I think one of the implications of these trends in diabetes complications, mainly related to blood flow, is that there may also have been sort of spillover effects or beneficial effects to the brain. The fact that people are having fewer complications related to vascular problems in other parts of the body, we think has also been a positive thing for the brain, and I'll show you some more information on that in a bit. This is a bit of a complicated slide, but I think important to think about in terms of the socioeconomic disparities in cardiovascular risk. So I sort of just showed you sort of pool data for everyone, now trying to break this out by socioeconomic status in terms of trends in cardiovascular risk. Let's try to focus on the middle pane here first. The top line is people who are at or below the poverty level. This is all United States data from the NHANES survey. The next line is middle income people. Lower line is sort of high income. And you can see that between sort of about 2000 and 2014, this is in the systolic blood pressure measurements separated out by socioeconomic status. Really no change in blood pressure control among those in the lowest economic strata in the poverty level. Some decline in middle income, significant decline among high income people. Similar trends in, this is smoking right here, again low income here, middle income, improvements in high income. If you sort of put it all together, this is a sort of overall cardiovascular disease risk model, like the Framingham stroke model, sort of putting together all the various risks, hypertension, smoking, high cholesterol. You can see a significant decline among high-income people, actually a bit of a blip upward in low-income people. So important issue in terms of increasing stratification and disparities in our country around cardiovascular risk. And again, if you buy my argument that cardiovascular risk really has an important effect on people's brains, probably in risk for dementia and Alzheimer's disease also. All right, turning now to another important trend, separate from the medical side of things, turning to social factors. Here's the trend in how long people are going to school, or how much schooling people are getting around the world. And this is, so the bars here show the fraction of 30 to 34-year-olds who have completed college. And this is in high-income countries here on the right side of the slide, lower-income countries here. And again, you can see the huge increase trends both in low-income and higher-income countries in terms of the number of people going on to secondary or beyond secondary education. So big education boom, people going to school for more years in both low-income and high-income countries, getting college education. The other end of the education distribution, literacy rates have had a similar trend, so more people able to read around the world in low-income and high-income countries. And so why is that important? So we think that education and brain health are actually quite closely connected, or I should say, first of all, just to show you again the numbers from the United States, people reaching older age, 65 plus, with more education. So here in the United States, again, about half of 65-year-olds had finished high school in 1990, up to 80% in 2010, similar trend in college education. And again, it's thought that education has an important impact on later life dementia risk because of how education or challenging the brain in general affects the actual biology of the brain, how what you do as a kid up actually through older age, how you interact with the world, the challenges that you try to mull about and in terms of interacting about ideas and interacting with people actually changes the brain's biology. And that general idea is called cognitive reserve, that you're sort of wiring up your brain in a way that will allow you to compensate for the Alzheimer's proteins, compensate for small strokes. So the same amount of pathology in the brain for someone who's gone to school longer, we think that person has a lower likelihood of Alzheimer's disease and dementia than someone who doesn't have as much reserve. But again, as in all of epidemiology, it's much more complicated than that. People who have more education have lots of other differences, not just in the biology of the brain, we think. Obviously, they, as we saw, less likely to smoke, more physically active. They go on to jobs that challenge their brains in different ways throughout life. They marry different people. They have different networks and different amounts of wealth. So it's likely that the amount of education that you get affects your brain health in lots of different ways and complicated ways. So again, putting this piece of the talk together, or trying to summarize this, we think that there are lots of modifiable risk factors, or we think there are modifiable risk factors that actually, if we can address them, may decrease the number of people with dementia. And again, there's been some estimates of about 30% of Alzheimer's disease cases worldwide are related to these modifiable risk factors that we just talked about. Low levels of education, cardiovascular risk factors, depression, which I haven't talked about specifically here. So if we can affect those risk factors, we think we might have an important way to prevent dementia in the growing number of older adults. Here's more proof of the connection between exercise and the brain. This gentleman here was looking for some muscular outcomes, I think, but got cognitive outcomes instead. And this is also one of the mice we have at the University of Michigan that's been randomized to high levels of education. You can see that has affected his brain health in certain ways here too. That's a Loyola mouse. That's oh, we're getting into basketball. That's getting dangerous. Don't get me started here yet, Tom. All right. Okay, so now I'd like to turn to, again, some of the studies we've done with the Health and Retirement Study to try and look at this question: how has dementia prevalence changed over time in the United States? And looks like we're good on time here. So just to tell you, again, a bit about the HRS, the Health and Retirement Study. Tom and Daniela, I think, both mentioned a little bit about it. This is a big study at the University of Michigan going on almost 30 years now. Like your registry started in 1990, actually, the grant. We started collecting data in 1992 following about 20,000 older adults, or actually not older adults, adults 51 and older. So both middle-aged and older adults, since I'm there now. That's right, young and old. And it's, again, based at the Institute for Social Research at Michigan. We collect lots of data I'll tell you more about. We do half of our interviews face-to-face. An interviewer goes to these people's homes and asks them a whole bunch of questions and takes some blood, checks their balance and their gait and grip strength and things like that. All of the data are made publicly available. You all can go leave the lecture and download all of these data right after the lecture from the HRS website. So because of that, we're proud of how many publications, about 3,500 publications using these data have been published, more than 2,000 authors. This last year, about 200 papers. So almost every other day, a paper using the HRS data is published. Here's just to show you a little bit more about the kinds of data that we collect. The information in red, which I realize you can't see very well on these colors. Physical and functional health. We do cognitive testing within the HRS. I'll tell you some more about that. These important family transfers, how much time people spend, again, providing care. Lots of other information. Some of the sort of innovations of the HRS, we also we ask people to give, or we ask for their permission to link their data from Medicare, so we know sort of how they interact with the healthcare system. We get lots more information about procedures that they've had done, diagnoses. Again, we collect some blood now. We've done genotyping on about 20,000 people, so we've got lots of information about their genetics too. Just to show you a little more about sort of the structure of the sample over the years since it started. Again, started in 92. Started just with 51 to 61-year-olds, and then actually the next year started collecting data on an older cohort. And then in 1998 is when we actually filled in the full age range from 51 and older. So since 1998, the HRS has been representative of the entire U.S. population, 51 and older. And then every 6 years, we enroll 51 to 56-year-olds to kind of keep the cohort refreshed and representative of the entire adult population. So we did that in 2006, 2010, and 2016. And we're just going into the field now for the 2018 wave. I started working with HRS in 1997 when I was 34 years old. and I thought of it as a study of these really old people. And I just became eligible for the study in 2016. So everyone seems so much younger within the sample now that we're doing work with. Mentioned to a lot of the folks we talked with today, one of the really fun things for me has been the sort of international growth of the health and retirement study. As people at the National Institute on Aging have worked with other research groups around the world to start up similar studies that are patterned on the HRS, Mexico, Brazil, lots of European Union countries, India and China, South Africa. So it's been fascinating to work with other groups around the world trying to understand aging in different places that have very different healthcare systems, very different education systems, with the idea being that as we collect comparable data from around the world, we'll be able to learn more about aging both in the United States as well as countries around the world. Again, here's how we measure brain health or cognitive function in the HRS. We use a cognitive instrument called the Telephone Interview for Cognitive Status, or TICS. It's kind of like the mini mental state exam for those of you who do clinical work. Test a whole bunch of cognitive functions you can see here. We also ask people just to tell us how they think their memory is doing. Are you doing excellent, very good, good, fair, or poor in terms of your memory, their functional limitations, prior diagnoses, things like that. Other things, again, that we think are important related to brain health, things like cardiovascular disease. We measure people's blood pressures. We have all information about their acute medical events from their Medicare data, genetics, education, et cetera, et cetera. Those of you who work in this area know that if you really want to understand the full impact of dementia and Alzheimer's disease, you can't just depend on interviews of people, the people with the disease, because as they become more impaired, they can no longer answer your questions and drop out of studies. So important to have information from proxy respondents or informants about people that they're taking care of, and we do that in the HRS. We also, even when someone dies, we don't let them off the hook. We do what we call an exit interview, which is we actually go to the next of kin and ask about the end of life, things like advanced directives, nursing home care, hospice care, and things like that. So lots of interesting studies about important issues of end-of-life care have come out of the health and retirement study. We also did a more intensive study of dementia in the 2000s called the Aging Demographics and Memory Study, where we chose a subsample of the HRS folks, went to their homes, did a full neuropsych assessment, neurologic exam, collected lots more information in order to get a more sort of clinically valid sense of whether that person has Alzheimer's disease or dementia. And we then, and a panel of experts, looked at all this data and made a diagnosis of dementia or not, and Alzheimer's disease or vascular dementia, et cetera. And then we used that intensive information from the ADAM study to try to get a better sense of who throughout the entire health and retirement study. So we did that intensive, expensive data collection on 850 people, but now use it to try to get a better sense of who in all of the HRS, even if we haven't done that intensive assessment, using the cognitive tests that I talked about, they're calibrated to that ADAM study. So for the study that I'll show you, we sort of use that HRS cognitive scale to sort of draw a line in order to make the prevalence of dementia the same as it would be with that intensive ADAM study. So for this specific study, again, the general idea was to try to stratify people in 2000 and 2012, the 65 plus population, use the same measures in both years and basically get a sense of who meets our dementia criteria in 2000 and then in 2012. And then put in these the variables that we think are important: education, big change in education as we talked about, cardiovascular risk factors, to get a sense of if there was a change, what was driving that change. And here are a quick review of the results and data here. So in 2000, again, about 10,500 people in the sample, 10,500 or so in 2012 too. Age was similar between the two years, although what's not shown here is that there were actually a greater proportion in the oldest 85 plus, as you'd expect in the 2012 group. Here's that big increase in education that we talked about. In 2012, the older adults had almost an entire additional year of education compared to 2000. So again, this is across a population of more than 10,000 people. So a big increase in education, also increase in wealth between those 2 years. And here's some of that, the cardiovascular risks that we talked about. Big increase in diabetes, some increase in heart disease, hypertension, obesity showing up in these data like in other national data. And then here was the punchline from this study that, in fact, we did think that the rate of dementia, or the prevalence rate, how many people in the 65 plus population in the United States had dementia, or I should say, again, the proportion of people 65 plus who had dementia declined significantly from about 11.5% to 9%. And this decline we saw across the age distribution, younger, old, middle, old, older, old. So it seemed like there was things going on across the entire age range of older adults in the United States. And then, I'm sorry, this is hard to see, but just again, trying to understand some of the variables that were related to this change in dementia prevalence. This top row here is an odds ratio. Ones that are below 1 is saying that there's a lower risk of dementia in 2012 compared to 2011. And when we put in things like education and wealth and race, you can see that one of the issues there, again, back to those SES differences and racial differences, that blacks and Hispanics had increased risk for Alzheimer's disease and dementia even after controlling for wealth. But you can see that there's still a significant amount of this change that's unexplained. This is still a bit of a mystery to epidemiologists and to people studying this. We don't know all of the factors. Again, the complexity of what goes into risk for dementia. There's still things to learn. To place our study in the context of other studies of these trends around the world, there's actually been a growing number of studies in mainly high-income countries that have found the same kind of trend, this sort of optimistic trend of a declining rate of dementia. You can see again in studies in England, the Netherlands, Sweden, and other places, as well as other studies around the United States too. So it does seem as though, again, I would never, as all of you folks who are in epidemiology PhD students, you never want to just go with one single study. You sort of want to see what's out there in literature and studies that are done different ways. So it does seem as though in different places, using different methods, that this decline in dementia risk seems to be true. And this was a review I did with some colleagues to look at some of these early studies. Again, in the United States, this was an earlier study we used using the health and retirement study in Rotterdam. And I just wanted to, again, highlight across all of these studies, sort of increasing levels of education and vascular risks were thought to be drivers of this optimistic trend in dementia risk. And then finally, just to beat a dead horse here, this was a recent meta-analysis of lots of different studies of trends in dementia incidence and prevalence. These are the prevalence studies here. I know you can't see the individual ones, but basically to the left of the line means declining risk over time. And most of the studies, especially the incidence studies, suggesting again that there's been a decline in incidence in studies around the world. So again, I think that in general is optimistic news about dementia prevention. We talked about how do we prevent people from getting Alzheimer's disease and dementia. I was on a panel on the National Academies of Sciences that did a review of the literature on what are the things we can do to help prevent dementia. Our panel sort of came down with this relatively lukewarm advice. We can talk about some of that, or why we had to do it this way, but encouraging but still inconclusive evidence for physical activity, hypertension control, cognitive training, keeping people's minds active as they age. A group from the Lancet in the UK did a similar study. They looked at a wider range of interventions, also came to the conclusion that, again, education, cardiovascular risk factor control, interestingly, hearing loss, depression, social isolation, all factors that we think increase the risk for dementia and may be preventable by addressing these things. I like this graph from that Lancet report, which tried to sort of lay out various types of ways to prevent dementia and Alzheimer's disease and the mechanisms for that. This top circle there is increasing brain reserve or cognitive reserve, as we talked about, with education, preserving hearing, keeping your brain active, having rich social networks, staying connected to people and activities, and then again, reducing brain damage, exercise, diet, hypertension control, all important, and reducing brain inflammation, various ways to do that. Again, exercise, diet, thought to be important in those pathways. All right, so just to wrap things up and bring things to a close here, again, we think our study with the health and retirement study suggests that the dementia prevalence appeared to decline in the United States between 2000 and 2012, again, in line with lots of, or increasing number of studies, both in the United States. The Framingham Heart Study published a paper in the New England Journal also a couple years ago showing that England, other high-income countries. We think that rising levels of education and perhaps the cognitive reserve that goes with that in more recently born cohorts may be contributing to a decrease or decline in age-specific dementia risk. Better control of cardiovascular risk factors, we also think important contributor. So it does appear that primary prevention of dementia through social and behavioral interventions appears possible and valuable. But, as Niels Bohr said, prediction difficult, especially about the future. So some unanswered questions that I think will affect what's going to happen going forward in these trends. Certainly, how will population levels of cardiovascular risk factors change in the coming decades? We talked about that big increase in obesity and diabetes. Sort of the cohorts behind the baby boom, many people in that cohort will have spent much more years with obesity, with diabetes. Will the risk sort of level out and then perhaps even increase going forward because of these, because of the diabetes increase and the obesity increase? And will the trends be different in high and low income countries? I talked a lot about education and how important that is, but in many ways I'm just sort of waving my hands. What exactly is education? In all these studies we basically just say how many years did people go to school, but it's still really unclear what is it about education that affects the brain in a good way. The active ingredients, so to speak. Can we figure out what those are? Can we make sure that everyone in the United States, everyone in the world gets those important, gets exposed to those important aspects of education? And again, I think there's lots of interesting research among actually people here in South Carolina that we talked about today and other places trying to understand what is it about education. How can we bottle that, so to speak, and get it to everybody? This is more on the clinical side. There's lots of sort of interest and debate right now in the general medicine or primary care world about what exactly is the right target for blood pressure control, for diabetes control. There's been a number of studies that where we do more intensive blood pressure control among older adults, and we think that would improve cognitive function, but in many of them it hasn't. And again, I think it's still unclear as to when during the life course it's really important to have blood pressure controlled. It seems as though midlife, again, 40s, 50s, 60s, blood pressure control, diabetes control, physical activity may be very important during that time of life. As people get into their 80s, it might actually be perhaps better to have a little bit higher blood pressure. But again, very unsettled questions that will be important going forward. Again, this sort of, I guess I'd call it shameful increase in disparities in our country. Why is brain health and life expectancy becoming so unequal across race ethnicity, socioeconomic status. I showed you that those data there for cardiovascular risk. Important that we address, that we document and address those growing disparities. And then just more generally, who will care for the growing number of older adults with and without dementia? Again, remember that slide with the huge increase in the 65-plus population, kids not keeping up with that. Who's going to be taking care of older adults as they get into older ages and may need help? Finally, just to again acknowledge my co-authors on that main study that I talked to you about, Eric Larson, Eileen Crimmins, other University of Michigan colleagues, and also our funding, again, from the National Institute on Aging and the Social Security Administration. And thanks very much for your attention.